Our next speaker is Tristan Margetson from Stanford. Tristan has been at Stanford for 20 years and has experience at a few other pediatric institutions, and she's passionate about educating in the field of perfusion. And in case you missed yesterday's session, it was her birthday. Happy birthday. Today she will be talking to us about hyperoxia. It's a topic that I'm very interested in. I'm very much looking forward to this talk, and I welcome Tristan to the stage.
Good morning. Thank you everybody for joining us. I'm here to talk about hyperoxia, specifically hyperoxia in infants. But I realized as I was putting my slides together that this is one of those topics that everybody has really strong opinions about. So I figured I might as well let the data do the talking for me. Hold on. Oh, we got it. Okay. Okay, so nothing to disclose for this talk. But today I wanted to start by reviewing the history of hyperoxia and then take a look at literature, both in adults and pediatrics, and what current practices look like. Then I wanted to tell you about our study at Stanford and what we found out, as well as where this is going in the future. Okay, so why do we care? We know that cardiac surgery is associated with multi-organ dysfunction, AKI, hepatic impairment, myocardial damage, post-op neurological deficits. And all of this is possibly due to oxidative stress. So does avoiding hyperoxia decrease oxidative stress and reduce the severity of multi-organ dysfunction? Does hyperoxia have an impact on morbidity and mortality? And if so, what is the number that we need to increase it or decrease it? What's that magic number that we should all be shooting for when we're on bypass? Just out of curiosity, I'd like, just by a show of hands, where do you keep your PO2? 300 to 400? Just a show of hands. Okay, a few people. 250 to 300. Okay, how about 2 to 250? I'm in that cohort too. 150 to 200. Okay, how about 100 to 150? Okay, that's nobody. If you're joining us online, everybody in this room raised their hand for a different number on that, showing us just how variable our practices are with PO2. So where did this start? Historically, cardiac surgery patients have all been managed with supraphysiologic intraoperative oxygen levels to protect against the risks of cellular hypoxia. They're just inherent in the unphysiologic nature of surgery and cardiopulmonary bypass. So I think when we first started, we thought we'll keep the PO2s really high because of bad bypass, we'll just have a lot of oxygen floating around. Well, what's all that oxygen doing to our patients? In 2012, Robert Young published a great article on the risks and benefits of hyperoxia. So let's go through a few of them. So let's start with the benefits, the good stuff. Hyperoxia has been shown to be effective in preconditioning of the myocardium to better-tolerate ischemia. And this was in an animal model, but it's been pretty effective in a couple of different studies. And the second benefit, possible benefit, is also again in animal models, was a reduction in the GME or gaseous microemboli that was generated during cardiopulmonary bypass. And this was from a 1999 study where Nollert looked at the generation of GMEs in piglets that underwent bypass. And they found that animals that received a lower FiO2 of 20 to 40% had significantly more GMEs than the animals that had 100% FiO2. And finally, one of the benefits of hyperoxia is lower wound infection rates. It's been shown in adults to lower wound infection rates. Okay, what about the risks? What are we looking at there? Let's start with myocardial reperfusion injury. In 2002, a new company looked at adult patients that had PO2s for 450 to 500 versus 2 to 250. And after cross-clamp removal, the cardiac index was much lower at 3 hours and 30 minutes and 3 hours after in the hyperoxic group. But that difference sort of equilibrated around the 6-hour mark, but the study still showed us that there was myocardial injury in hyperoxia. A second risk is the generation of systemic oxygen reactive species. And this isn't just in the myocardium, it's been shown in many studies that it's systemic as well. And finally, one of the major risks is lung injury. And there's lots of evidence to support the adverse effects of high inspired fractions of oxygen. And in 2000, there was a study that showed the higher the percentage of FiO2, the greater the delay in recovery of lung function. But what about hyperoxia and cerebral protection? Well, when you look at the literature, the jury's really out on this one. In 2014, there was a study that showed that after a major stroke, hyperoxia was associated with an increase in mortality. But then in 2002, there was a study that showed that hyperoxia reduced the infarct sizes if you had a stroke. So we could go either way on that one. And what about deep hypothermic circulatory arrest and keeping a reservoir of oxygen around for tissues? Well, in 1999, Nolert, who was really into this, studied 5 animals in each cohort. And the first cohort had a PO2 of 64 to 181. The second one was 400 to 900. So big variation in the PO2s. And after 30 minutes of DHCA, they fixed the brain tissue and sampled it. What they found was the brain damage was greatest in the Normoxia group due to hypoxic injury, but there was greater free radical damage in the hyperoxic group. So again, no clear-cut evidence on that. Well, what about pediatric hypothermia and hyperoxia? I wanted to give a shout out to Carrie Stryker, who gave a great talk at AMSEC this year about oxygen pressure field theory. And she was kind enough to share her information with me. And we had a lot of really good long talks about our practices. It was really fun. But just as a review, oxygen pressure field theory suggests that hyperoxia just before you arrest takes advantage of increased oxygen solubility and reduced oxygen consumption to load tissues with excess oxygen. And there was one study by Jeffrey Pearl and Gary Grist in 2000 that looked at hyperoxia and acid-base management in pediatric patients. They had 4 different treatment groups. They had alpha-stat with normoxia, alpha-stat with hyperoxia, and then pH-stat with normoxia and pH-stat with hyperoxia. And in both hyperoxic groups, there was less acidosis after arrest than the normoxia groups. And the pH-stat hyperoxic group had less acid generation than all of the other groups combined. So this pre-arrest preparation by oxygen loading tissues can delay the conversion from aerobic to anaerobic metabolism, thus extending a safe DHCA time. At Stanford, we don't use any arrest, actually. I can count the number of times on my hand that we have had to stop the pump sort of urgently to put a few suture lines in, but we employ antegrade cerebral perfusion for all of our patients. Okay, so now I'm going to come at you with a ton of different studies and literature over the years. And I'll start with what's happening in the adult community, and then I'll transition to pediatrics and then talk about our study. But this was from 2006, so fresh off of the oxygen pressure field article by Gary Grist. There's an article that's published in JEC, and it was a small study with only 36 patients, but they had 2 groups. One had a PO2 of 150 to 250, and the other was 300 to 350. And what that study showed was that there was no difference in length of stay or time on a ventilator. So the hyperoxic strategy showed no evidence of improving outcomes. And I think at this point, we sort of thought hyperoxia would help out, but the literature wasn't supporting that. Meanwhile, the evidence is mounting up in the ECMO space for sure. Through the early aughts to now, hyperoxia and ECMO is pretty well documented both in the adult and pediatric population. This is a study from 2021 that sort of summed up all the other studies during that time period. And this was about ECMO and eCPR, but it gives us a good idea of what's happening. They included 44 patients in this study, and only 11 of the patients survived, and all 11 had low PO2s of 164. Everybody that died had a PO2 over 300. So they found that the mean PO2 correlated with the severity of hypotension and the intensity of the vasoactives that were used, and that hyperoxia was associated with an increased mortality both in ECMO and eCPR. So I think it's pretty clear cut that hyperoxia is a no-go on ECMO. Now, by 2016, we've kind of swung the other way, and we think maybe avoiding hyperoxia is the way to go. So this was a study published in Anesthesiology, and it was multi-center and randomized and had 298 patients. And the study group, the PO2 was 75 to 90 by using a CDI 500. The control was by FiO2 titration to maintain an arterial saturation of more than 99%. So they looked at the incidence and severity of AKI, as well as serum biomarkers, the duration of mechanical ventilation, and the length of stay both in the hospital and the ICU. Guess what? They didn't find any difference in the development of AKI or other markers of organ damage or any difference in length of stay in the hospital. So again, no clear-cut evidence there. What about hyperoxia and cognitive dysfunction? In 2014, 1,800 patients were included in a retrospective study, and they hypothesized that hyperoxia during bypass would be associated with neurological decline, but that's not what they found. 6 weeks after, hyperoxia had no association between postoperative neurologic decline. Same time frame, we're hoping to prove hyperoxia is going to do something about rhythm. So 330 patients were randomly assigned either to a PaO2 of 450 or a standard group of 161. And here again, I think they thought that hyperoxia was going to help the rhythm at the end. But the results here showed that the incidence of post-op AFib or VTAC and MACE were very similar in both groups, so it didn't do anything for us. By 2021, we're looking at normoroxia again. And in this study published in Perfusion, they looked at 2 cohorts and found that the normoroxic group had a reduced myocardial oxidative stress when compared to the hyperoxic group. And I'll end on the adult literature with this one. So over the years, the studies have had really conflicting reports. So this group looked at 24 different trials, a huge number of patients, where they found that hyperoxia led to higher mortality, especially in patients that were post-arrest or on ECMO. So after all of this, I think what we've gotten out of it is we see that normoroxia reduces some myocardial oxidative stress, but that hyperoxia might lead us to a higher mortality, and we still don't have an optimal PO2 to shoot for. So switching gears here, we're going to move to the pediatric population. In 2022, JAMA produced an article with a systemic review of over 27,000 patients in 16 studies with patients that had cardiac arrest, traumatic brain injury, ECMO, and general critical care, and all of which said the same thing. They all had the same conclusion. Hyperoxia was associated with mortality in critically ill children. What about ECMO? Luckily, there's a huge amount of data on hyperoxia and ECMO in the pediatric patient. This is a study from 2016 where they kept the PaO2 about 193, and they found that it was an independent risk factor for 30-day mortality. These patients also had a longer duration of ECMO and higher flows, but as long as the PaO2 was below 193, that showed better results. Here's another one from 2018 with very similar outcomes. They had 8 hospital centers, and they defined hyperoxia as a PaO2 over 200, and they found that hyperoxia was associated with mortality. And one more that was just published this year in December, and this one's about cyanotic patients. This was by Asad Bashish, who's a guy from Stanford who now works at Emory, and he wanted to look at the patients that needed ECMO after Norwood operations. It was a retrospective that took place between 2010 and 20, and he wanted to see if there was a link between hyperoxia and mortality on ECMO. Here they found the PaO2 of 182 had a 5 times higher odds of mortality if you were over that number. They also had shorter duration to cannulation and higher lactates and higher ECMO flows. So same physiology for these patients, but if you raise that PO2, they had a dramatic increase in mortality. What about hyperoxia and AKI? Though I couldn't find anything in the literature to let us know what that number is, PO2 would have effect on AKI. My lovely friend Molly Dreher and her group at CHOP looked at DO2 and AKI, where they found that you needed a much higher DO2 to reduce AKI in children, 340 in neonates and 400 in infants. What about post-op delirium? This is a 2024 publication where they looked at hyperoxia in pediatric patients and was it associated with a greater prevalence of post-op delirium. It was retrospective, and they looked at a difference between 150 and 200, and what they found was hyperoxia had no association with delirium. What about hyperglycemia? This was an animal model in piglets that showed that hyperoxia triggered hyperglycemia, a hyperglycemic response, which is actually really interesting when you think about it, because it's something that we might be able to modify that might be impacting the endocrine system as well. And finally, the closest thing that we had to our study for research was a 2009 article by Caputo, who published on cyanotic children in bypass. And he had 67 patients, and they defined the normoroxic PO2 for this subset of cyanotic patients as 50, but the hyperoxic group was 150 to 180. And again, these are cyanotic children. They monitored inflammatory markers throughout the case and after the cross-clamp removal, and also 12 to 24 hours later, where they found everything was much lower in the normoroxic group. It was associated with reduced myocardial damage, oxidative stress, and cerebral and hepatic injury when you compared them to the hyperoxic children. Okay, so let's move on now to our study. We realized there was no data on the association with hyperoxia and outcomes in infants that were undergoing bypass. We had plenty of ECMO data, as we can see, but we really had a dearth of information on where we should keep our PO2s for children. So our hypothesis was that the hyperoxia during bypass was going to be associated with greater odds of morbidity, mortality, greater chance of AKI, and have a result of a prolonged length of stay. Our study was retrospective. We were kind of the first people to put our toe in the water on trying to do this. So it was retrospective, single center, and we included all infants under 1 year of age undergoing bypass. We had to exclude 2 patients who went on ECMO in the OR. So we had 469 patients, and their median age was 97 days, or just over 3 months. And their median weight was 4.9 kilo, and their bypass time was only 128 minutes. Let's take a look at some of our results. So a PaO2 of 313, so that's the magic number for this study, had the highest sensitivity with specificity greater than 50% for the association of operative mortality. In addition to that, over half of the patient population we looked at had hyperoxia on bypass, so that was, again, anything over 313. And I have a theory about why that is, because when we go on bypass, we use a CDI 500 and we calibrate that. We, go on bypass, we look at it, and then send a blood gas off downstairs. We don't, as of yet, still have intraoperative blood gas monitoring, but they tell us this year. So we send it off, we wait a half hour. When it comes back, we've noticed that there's a big discrepancy between what our CDI is reading and then what the first gas is. So we'll think we're delivering 250 and the gas will come back at 350. My colleague Don here can attest that this is sort of a routine situation for us. Okay, back to more results. So the infants with hyperoxia were more likely to have AKI and a prolonged length of stay and mortality. They were also younger, they weighed less, and they had longer CPB times and a higher STS mortality score. We found no difference in sex, race, preoperative creatinine, single ventricle physiology, or the presence of a genetic syndrome. When we did our multivariate analysis, hyperoxia was associated with greater odds of mortality, again, anything over 313. However, we failed to identify an association with AKI or a prolonged postoperative length of stay. And of note, hyperoxia was associated with greater odds of mortality in a subgroup analysis of neonatal patients, when I'm going to return to in a few minutes and tell you a little bit more about that. Okay, so what did we learn? We learned that hyperoxia occurred in a substantial portion of our patients that undergo bypass. We know that it's an independent risk factor for mortality and that it is modifiable. It's something that we can do as perfusionists to change things. And that hyperoxia was associated with a 4-fold greater odds of mortality within 30 days. However, we failed to identify an association with AKI or a prolonged length of stay. So this is late breaking data that came in for me last night. Last week, I was at a Little League game sitting with one of our intensivists. Our kids play on the same team. And he said, "What are you doing next week?" And I said, "Oh, I'm going to give this talk on hyperoxia." And he said, "Oh, really? I just finished looking at this." And I said, "Oh, great. Can you send me the data?" And after about bugging him by text for 5 days, I got it last night. So I wanted to put it in this talk and share it with you. It's unpublished data, so you're kind of the first to be hearing about it. And it's been submitted for approval and for publication. And the main authors are Asad Bashish, the guy who looked at this before, and then Chris Mastropietro, and then David Kwiatkowski. Give them the credit for this. Anyway, Stanford participated in a multi-center study with 29 centers that were looking at hyperoxia on bypass in neonates. And this study had 2 goals. The first was to talk about the variation of oxygen exposure during bypass within centers and among centers. So our hypothesis is that we would see variation in PO2s between different centers, just kind of like we just did in this room. And that we would commonly see superphysiologic PO2s, that most people would be having high PO2s. Secondly, we wanted to determine if there was a relationship between PaO2 exposure with bypass and postoperative clinical outcomes, mortality, and MACE events. So here we hypothesized that the neonates who were exposed to higher levels of PaO2 would have worse clinical outcomes. So this is going to answer question number 1 pretty quickly. This across the bottom, you can see those are all 29 centers that were involved in the study. And up top, you can see where the PO2s fell. And as you can see from this slide, it's all over the place. So everybody is running their PO2s in different different locations. Sometimes even within an institution, you can see that their PaO2s are all over the place. So we were able to confirm just how much variation we have between our practices. And you'll note how few centers run PaO2s below 200 and how few centers run them above 600. And finally, you can see postoperative mortality for the entire cohort that we studied and also for subsets of cohort by PaO2. So on this slide, the yellow PaO2 is anything less than 200. The blue is 200 to 300. The green is 300 to 400. And the red is anything greater than 400. And it's pretty clear to see how low the operative mortality is when your PaO2 is less than 200. And the higher mortality exists with patients that have PaO2s above 400. Across the bottom, you can see we have our transpositions, hypoplast, single Vs, and stat 4 and 5 cases. I was really interested in the hypoplast data because here it shows that patients that had PaO2s over 400 had a 22% mortality, but patients with PaO2s below 200 had no mortality. So where are we going for here? Of course, we need more data, and especially between our various patient populations, a single ventricle, 2 ventricles, we need to be looking at different things like that. Our cyanotic patients versus patients that are fully septated, as well as integrating all our practices together from around the country. I mean, just in talking with perfusionists at this meeting or even my talk with Carrie, we have varied practices, so it would be great to come together and figure out where we need to go from there. And this is just, if you wanted to read a little bit more about those studies for yourself, this is just a slide for references. That's it. I'm happy to take questions. Not from you, Greg, not from you.
Thank you very, very much. That was a great presentation of all the available literature. And what I was thinking about most during your presentation was Dr. Rob Baker's presentation earlier today, where we're developing registries in different parts of the world, and Dr. Baker talked about linking those to have a worldwide registry. And I really think that oxygenation strategy is important. And something else that we've talked about at the conference is it may not be one size fits all for adults, peds, risks for AKI or other
or even
issues.
with the peds practice, in like cyanotic patients might need something different than septated patients. You're right.
Yes. So thank you for that excellent review of the literature.
And I really channeled my inner Rob Baker on that one.
Bruce.
Well, now you already scooped my question. This is Bruce Earls, provision in Warehouse, Syracuse. I was going to comment on what you summarized there. Was that my understanding of hypoxia? Hypoxia and hyperoxia has always been, it's a combined effect. So just adding a hyperoxia to a well-perfused patient isn't as damaging as adding hyperoxia to a patient who was previously hypoxic.
Yeah.
So it would be interesting to go back and categorize the studies that way and see if it revealed kind of what your last slide started to reveal, is the children with hypoxic congenital defects were profoundly affected by this. Mm-hmm. And so it's a two variable thing. That
yeah.
Could be
it's not a one size fits all situation for sure.
Tristan, that was a lovely presentation. It really makes me think about the need for a randomized controlled trial in the area, but not only the need for it, but the absolute mandatory need for it. One of the United Kingdom surgeons, Tim Jones, talked about the concept of enrolling all pediatric cases in randomized trials or trials of some sort, because there's so little knowledge, good quality knowledge out there. And this is an example of an area where you've got so many centers in the US. If you all work together, you'd have this in a year. You'd have all the answers in this particular hyperoxia setting. Your data is very compelling. It's a little bit difficult because I couldn't see the N values clearly for the less than 200 group, and that does make a big difference because clearly there was a smaller cohort. But in some of your other groups where the differences were, you're 22% down to 15. I mean, it's striking data,
right?
And action needs to happen.
Right.
not just pontification.
Yeah.
Well, what is the prevailing thought on hyperoxia immediately before antegrade cerebral, like you guys use and we use, or circ arrest cases? I mean, I normally run low oxygens until right before, and I'll crank it up. Is that still something that's being utilized?
You know what, Steve? I looked at that and I tried to figure it out. And the only literature that supports any kind of philosophy is that 2000 article by Gary Grist and Jeffrey Pearl. So I'm not sure we know the answer. I mean, that was actually a small study, but it's what everyone does, including us. So.
Hi. Sorry.
Hi, Erin.
Erin from DC, DC Children's. I actually have three things.
Uh-oh.
So one of them is a comment, and just that after watching that presentation last night, our institution prior to a few months ago did 100% FiO2 on every case, mostly because we wanted to get rid of the nitrogen. And so after watching that last night, I wonder, is there another option of helium or, some other thing instead of, room air to mitigate the nitrogen without increasing the oxygen?
So yesterday I had the pleasure of attending Spectrum's afternoon session where they've developed a hybrid model and an oxygenator that can do something similar to that. So it's something to watch for sure.
That is very interesting.
Yeah.
And I had two questions for you. The first was about your retrospective trial. Looking back, you said a significant portion of your kids had hyperoxia and some didn't. And so I was wondering first, what was the difference? Like, how did that happen? Because all of our kids had hyperoxia.
Yeah.
For running, is it different on perfusionist, or was it different depending on the surgeon or the patient?
I think it's actually lab driven, like I was mentioning, because we thought we were going on with PO2s around 250, but then we would get the lab value back and it was 350. So I think most of us shoot to be below 250 on bypass. We definitely don't run 100%. We don't go on at 100%. We go on at 70 or lower. And it depends, of course, on what type of case it is and what the patient came in with. But I think that's a lab driven thing. Hopefully when we get our ABLs, that'll make a difference.
All right, and then the second one, your last slide with the new information.
Yes.
That had the hypoplast
Let's go back
way
to it.
higher than everybody else.
Mhm.
I'm wondering if they gave any information on whether or not those hypoplasts were deep hypothermia, circ arrest, cerebral perfusion, anything like that to explain.
I was so lucky to get these slides last minute that this is all the information that I have. But I was still excited to show it to you and present. And I will tell you that this cohort had over 1,175 patients enrolled in it. So once they get most of the data out and that they can publish it, I think we'll know more about the specifics. And then, maybe next year I can bring that to this group too. But it was a little taste of what's to come for sure. One from online. Okay.
Question from the virtual audience. Do you use free radical scavengers? Given the info you've gathered, have you changed the use of these?
Okay. Yes, we do. We use mannitol, but mostly like everybody else is, we're giving a dose before we go on pump, and then we're also giving one before the cross clamp comes off if we are cross clamped. I'm not sure that that's going to make a difference. I know hyperoxia can overwhelm some of the capability of something like that. So it's something to think about for sure. Great question.
Thank you very much.
Okay.